Introduction. Perioperative care refers to the comprehensive of a patient before, during and after a surgical procedure. Actually, comprehensive care, it should be comprehensive care of a patient before, during and after surgical procedure. It is perioperative things. So it aims to reduce surgical risk, optimize outcomes and ensure patient safety. So the motto of this topic is like that: how you resuscitate the patient, how you keep the patient safe, and after surgery he will be okay and he will be going home with everything okay. First is perioperative assessment, how we assess the patient. Every surgical domain or medical domain, when you are examining a patient, history is very important. In history, medical history, patient is having any medical diseases or anything. Surgical history, earlier any surgery done or any trauma surgery has been done. Then drug history is very important. What type of drug he is taking, maybe for his ailment like diabetes mellitus, hypertension, these cardiac diseases, coagulation and other anti-coagulant drugs. Then any allergies, you should inquire about allergies. Then social habits, especially social habits. First is smoking, then alcohol intake. How much he is drinking, how many years he is drinking, how many days he is drinking. Then smoking also similarly we have to ask. These are the history you should take. Then we will examine the patient. Physical examination is very important. You have to take all the vital parameters, how we examine the patient, details. Physical examination is needed. Then risk assessment. Risk assessment, one is ASA classification, that is American Society of Anesthesiologists. They have given a classification how to assess a patient according to some parameters. We have to assess the patient whether he is safe for surgery, safe for anesthesia. Those things are very important. Then any cardiac risk. Some index are there like revised cardiac index, cardiac risk index. So we have to assess those patients. Then pulmonary risk means any chest problem, any COPD or any other respiratory illnesses this patient is suffering. We have to see this patient and assess him accordingly. So these are risk assessment. Perioperative assessment. I told you physical examination and risk assessment, ASA classification, cardiac risk, then pulmonary risk, then investigations. The investigations are based on age of the patient, then any comorbidities patient is having or any surgeries earlier. The investigations like CBC, complete blood count, then respiratory function test, then LFT, liver function test, then ECG, X-ray chest, then coagulation profile, like platelet count and BTCT. Those things are very important for assessment, investigations. Preoperative assessment, you have to see all those investigations we are asking from the patient. Then coagulation profile, then consent, very important thing. Consenting, we usually tell it as an informed consent. First is you inform the patient about the procedure, what type of procedure you are doing, like whether it is a major surgery or minor surgery, how much you are cutting, then benefits of that surgery you have to. These days, earlier time no informed consent was there. These days you have to assess those things. You have to ask the patient, take his consent by telling him that how much you are cutting, what is the surgery you are going to do, what are the risks he is facing, and how you will be allaying those things. So the informed consent is very important, and he has to sign there. And sometimes his relative also, if patient is not cannot sign it or he is under sedation, his patient party or relatives has to do that. Then benefits, then alternative surgery, if it is available, what is available to you, you have to tell him, and then he will be signing it. Now optimization of the patient. We have to optimize the patient that he will not suffer any untoward incidents. One is we have to control hypertension. If patient is hypertensive, we have to start with antihypertensive drug. Then if he is diabetes, we have to control his blood sugar. Especially sometimes insulin have to be given in those patients, injectable. If his blood sugar is not controlled with oral antibiotic drugs, we have to start with the insulin. Then treat infections. If patient is having any infection like chest infection he is having, or maybe a gallbladder surgery you are going to do, he is having cholecystitis, still infection is there, patient is running fever, in that case you have to treat those infections in that. Then correct anemia. Sometimes patient is anemic, in that case we have to start with the correction of anemia. Then electrolyte balance has to be maintained in those patients. Then smoking cessation means you should stop smoking. You ask the patient not to smoke at least more than or equal to 4 to 6 weeks of is preferred. Ask the patient not to smoke for 4 to 6 weeks. Okay. Then nutritional optimization. The food intake and other things you should tell him what to take. So optimization has to be done. In nutritional status of this patient has to be improved. Then prehabilitation means before operation you have to rehabilitate him. That is like exercise. You ask the patient to do some exercise, that is important. Or chest physiotherapy is very important. Some physiotherapy is available to us, in that we have to do that chest physiotherapy if patient is having any respiratory problem and other things. After doing all those before the surgery, you have to prepare the patient on the day of surgery. Day of surgery, what will you do? There are fasting guidelines. How many hours he has to refrain from eating. First is 6 hours of solid. He should refrain from taking any solid at least for 6 hours. Then 2 hours for clear foods, water and other things. He can take and ask him to stop it before 2 hours. Ask the patient not to eat for 6 hours and 2 hours for clear fluid. Before 2 hours he can drink clear fluid. Then bowel preparation is important. Actually, the day before surgery, we have to ask the patient to take some laxative. Laxative we used to give the patient, and his bowel will be clear, because some abdominal operations or some other operations also do. The passage of stool or defecation is very important. Okay, so in that case, you can, if patient is constipated, you have to prepare him by giving enema. Enema can be, you can start with enema and other things. Then preoperative medications are important. Some preoperative medications, if patient is taking beta blockers, he should continue with beta blockers. He should continue with the beta blockers should continue, and then stop anticoagulants, then antiplatelets, depending on the surgery, depending on the time of surgery, what type of surgery you are going to do. Accordingly, you have to ask him to stop these anticoagulant and antiplatelet drugs. So you have to ask him not to take it. Especially for antiplatelets, you have to stop at least 7 days before. You ask him not to take those, because when you are doing the surgery, he may suffer from hemorrhage. In that case, he should not take this. So optimization of the patient is very important. Then prophylaxis. Some prophylaxis are very important, like antibiotic prophylaxis we used to give. In Western country, they will not give any antibiotics, because they have a clean type of atmosphere. Their operation theatre is very good. Our operation theatre are not that secured. No? Sometimes infection may be there, especially in our surgery of like cholecystectomy or appendicectomy or hernia surgery. Sometimes the prophylactic antibiotics has to be given. It should be given 60 minutes before the incision. It should be given not just before surgery. It should be given 60 minutes before incision. Then deep vein thrombosis prophylaxis is very important. If the patient is having a prolonged surgery like orthopedic surgery or cardiac surgery or other surgery which will be spanning for many hours, in that case the compression stockings are suggested. Compression stockings, he has to wear that stockings usually. And another thing is low molecular weight heparin. If you think that patient may suffer from deep vein thrombosis, because this way he can suffer from pulmonary embolism and other things, in that case the prophylaxis has to be started, like compression stockings and low molecular weight heparin. After that, intraoperative care. After finishing the preoperative assessment and other things, now our turn for intraoperative care. What are the things we will do while we are operating? One is operating room preparations. First is sterilization and asepsis. The sterilization has to be maintained in OT. All the instruments has to be sterilized very nicely, like autoclaved usually. Sometimes gamma sterilization also available. We can do that, like laparoscopic surgery. The instrument has to be sterilized according to the instrument used. Like then the equipment check is there. Anesthesia machine. We have to ask the anesthetist brother to see for anesthesia machine whether voice apparatus is good, his oxygen connection is good. Then for laparoscopic surgery, carbon dioxide also needed. So the anesthetic machine are very important, and monitors has to be proper. Like you have to see the oxygen level, then cardiac monitors are there, and ECG monitors. Those things are available. So you have to check it before starting the operation. So these are the equipment check. Then positioning and padding to prevent pressure injuries. Positioning. We have to make the patient lie down on the operation table where no pressure areas are there, should be there, and which should, or sometimes cauterize, we use a cautery. No? In that cautery, you can burn his. It should be properly grounded. The foot pad is there. It should be properly grounded to the ground. There should not be any electric burn in the body, like especially in the lower limbs or where we touch that body plate. So those are very important things. Then monitoring the positioning and padding, it's okay. Then anesthesia management is important. Anesthesia management. Usually choice of surgeon, the anesthesia. One is general surgery, then regional surgery, local or combined. So these are the choice of anesthesia. General surgery should be done in a extensive surgery when you have to go for intra-abdominal operations. Some other like in brain surgery or like any coagulopathy or other things are there, like uh, different types of surgery which can jeopardize the patient's problems. In that case, anesthesia has to be decided what type of anesthesia you are giving. These days, even with our cholecystectomy, we are doing by spinal anesthesia, or sometimes appendicectomy and other things by spinal anesthesia. But if you are going for the laparoscopic cholecystectomy, in that case, general anesthesia should be given, because you have to do the surgery, do the extensive surgery. So these are few things important types of anesthesia, or sometimes local anesthesia also go for surgery. Then we can combine that general anesthesia with the local anesthesia, or sometimes you have to give the injection lignocaine in the local area to minimize the pain. So these things can be combined. And how you monitor the patient. Different monitors are available. One is ECG monitoring, then pulse oximetry has to be monitored, then non-invasive blood pressure monitoring is available to us. And these are monitors. Another is capnography. Capnography, how much carbon dioxide patient is inhaling, the level of that have to be done by capnography. And temperature monitoring is also important, especially temperature monitoring in a cold area or the place where sub-zero temperature are there outside. And the temperature monitoring is very important in that case. Now, surgical considerations. The patient has to be maintained hemodynamically stable. The hemodynamic stability has to be maintained, like the electrolyte balance and blood pressures has to be managed. Then fluid and electrolyte management is very important. How much fluid you have to give in these patients. In extensive surgery, the fluid has to be given extensively. So in that case, you have to see for any electrolyte problems. So fluid and electrolyte management is very important. Blood loss estimation. How much blood will be lost in a surgery? You have to assess it first. Or how much blood is losing. Means sometimes we count the pads, like the mop count. How many mops you are using in operating a case. So the mops has to be counted. Ask the sister how many mops we are using. Every mops how much ml of blood is lost. And if needed, we have to blood transfusion is asked for and we have to give it. There are some safety protocols are there. WHO surgical checklists are there. Like it is done like signing. When you see everything is correct, then you are signing it. Then time out. How many times, how much time you are using. Then last is sign out. Sign out means you have to measure everything, and whether everything is done properly. Checklist should be maintained. So these are the things WHO has given: the signing, then time out, and the sign out. This is safety protocol. We should follow this protocol. Then after surgery, post-operative care. Perioperative care, preoperative, operative, then post-operative care. Usually the immediate post-operative is PACU is important sometimes. Pre-anesthetic, this post-operative ICU is available to us. In any surgery these days, in good center, they are using the ICU facilities. In that, what they are monitoring? Airway patency. you have to see for airway, whether his oxygenation is good, his mouths are clean, then he is taking good breath or not, whether airways are clean or not. Sometimes patient can vomiting sometimes. There can be regurgitation of gastric contents. There you have to be very vigilant. Airway patency has to be maintained. Then vital sign monitoring. You have to monitor the vital signs like blood pressure, pulse rate, and oxygen, SpO2 and other things has to be monitored. Then pain management is very important. Pain management is usually we go by opioids or by NSAID. Then regional blocks can be used in those patients for pain management. Then you have to monitor the patient for any nausea and vomiting. If he is having vomiting, he can aspirate the vomitus, and that way you can get aspiration pneumonia. Patient will die also in that. So whenever your patient is in the ICU or in the postoperative ward, you have to see for any vomiting, whether he is retching or he is going to vomit out. In that case, you have to use some suction. You have to clean his mouth. The vomitus has to be cleaned. Then fluid balance monitoring. Fluid balance has to be balanced, like type of fluid you are giving. Usually ringer lactate we prefer, or sometimes if patient is hypoglycemia is there, you have to start with glucose also. Some other thing also. So the fluid balance monitoring is there by assessing how much you are giving. That is intake and output has to be monitored. By the intake you are seeing how many bottles of fluid you are giving. Then output is by catheterization. You have to see how much urine output is within this 1 hour or 2 hours. So we have to manage the fluid balance of these patients. Then assess for bleeding, shock and respiratory depression. Then you have to assess the patient for bleeding, whether patient is having any bleeding or not. Means you have to see the blood pressure. If patient is bleeding postoperatively, patient will be having low BP or his pulse rate will be more. So tachycardia may be there and patient may be in shock. So, and then respiratory depression also may be there. Then he may be gasping. So in that case, or his cyanosis may be there. So in that case, the assessment for bleeding, shock, respiratory depression, these things has to be monitored postoperatively in the postoperative wards. Then early postoperative care. What are those early postoperative care? DVT prophylaxis has to be continue. Deep vein thrombosis should not be there. It's very dreaded sometimes. Then early mobilization. You have to mobilize the patient as early as possible. You go to the postoperative wards. No? Then when you are postoperative round, we are giving after surgery. We are seeing whether patient is mobilized. Even you can help the patient to sit down and pat in his back. পিঠে মানে আস্তে আস্তে মারতে হবে, মানে respiratory should be started, not like that you beating the patient. Somebody will be telling that you are beating them. So not like that. So the early mobilization and giving some physiotherapy by patting that is very important. The nutritional status of this patient is very important. Usually you should prefer the early enteral feeding than possible. When possible, patient's bowel sound came out. Bowel sound is started, patient passed to, and no vomiting and other things. In that case, you can start oral feeding as quickly as possible. That will minimize the stress of surgery. So early enteral feeding is usually preferred. Then wound care. The surgery you have done, wound is closed properly, whether any soakage from that wound area, operative area is there or not, or the operation you have done, it may sometimes oozing may be there. So you have to give pressure bandage, you have to do the dressing again. Especially in thyroid surgery, we have seen the patient can die of the hemorrhage, and there may be blockage of airway when blood is accumulated there. So the wound care is very important. Whether the wound is properly managed or you have to do the dressing time and again. When there is bleeding and other things, you have to see for that wound, whether it is oozing or not. Then monitoring for complications. We have to see the patient for whether any complication occur or not. One is patient is having any fever, any infection patient is suffering, any DVT, then pulmonary embolism. DVT is there may be swollen lower limb, especially the thigh and the ankle area or other areas. DVT will be there. Then pulmonary embolism is very dreaded. Patient can die for that. So whether it is there or not, you have to monitor the patient. Then urinary retention. Whether patient after surgery he passed urine properly or whether he cannot pass it and the bladder is full. So you have to see that also, or whether any urinary retention occur or not. If it is urinary retention is there, catheterization has to be done in those patients. Then ileus means the intestinal mobility may be lost postoperatively, and you have to see for bowel sound, whether the bowel sound is normal, came out, or maybe increased or it stopped. Then see for any loss of bowel movements. So sometimes patient can suffer from ileus. So these are early postoperative care. Then late postoperative care. Late postoperative care, usually we start with rehabilitation. As I told you, the physiotherapy you can also give in the bedside, or you can ask the physiotherapist to help you. You come to the postoperative ward, especially in the trauma surgery or in case of any orthopedic surgery. So the physiotherapy is very important there. So rehabilitation and physiotherapy is very important. Then education on wound care and medication. So you have to educate the patient as well as his patient relatives for any wound, whether when you are discharging the patient, you have to ask for dressing, and stitches are not yet removed. You have to ask the patient party or patient also whether they have taken the wound care or not, dressing you have done or not, and the medications, what type of medication is needed, you have to give that, like antibiotic has to be started, postoperative antibiotic, oral antibiotics, and other medications like he may be diabetic, insulin therapy you have to see for the monitoring the blood sugar level. So blood sugar level monitoring is very important for those patients. Educate them. Then follow up and ask the patient for come to the OPD or for follow up in the hospital. These appointments has to be given. How many days after he will be coming? This is very important. Follow up appointments are very important. Then managing chronic post-surgical pain. If there is patient is suffering from pain, like a hernia you have done, patient is having pain in that area, in that hernia. In that case, the surgical pain has to be reduced. If it is there, anesthesia or NSID can be preferred in those patients. Usually, less extensive the anesthesia should be given in those patients. Like paracetamol is very important. It is less expensive also, and it is not that dreaded also, or less complication in that. So the anesthetic drug or analgesia drug should be given in that patient to allay the surgical pain. Now some protocol is there, enhanced recovery after surgery. It is there, you can write it like some modern approach to improve outcomes are there. How you minimize the extensive surgery. One is minimal fasting. Patient should not fast for many hours. Then carbohydrate loading. Sometimes carbohydrate has to be given like orally also, or like IV drip also. Carbohydrate loading can be started. Then avoid routine drains and tubes, because in surgery some bleeding may be there, like intra-abdominal surgery or other surgeries also. If you are thinking that bleeding may be there, in that case drain is preferred sometimes, and different types of drain there, like suction drain, then sump drain, then open drain, closed drain. So this type of drains usually they should be avoided if possible. So avoidance of routine drains and tubes are very important. Then opioid separation anesthesia. This is one important thing. Opioid sparing anesthesia. Opioid should not be given. Morphine and other things. These are the patient will be cannot move properly, or patient will be sedated. And the important thing is bed sore. Patient may suffer from bed sore in those cases. So the opioid sparing anesthesia is suggested in a modern setup. Then early mobilization. As quickly as possible, you mobilize the patient early. Then early feeding. So these are few modern approach to improve the outcomes. One is minimal fasting, carbohydrate loading, and avoid routine drains and tubes. Then opioid sparing anesthesia, then early mobilization and early feeding. So these are few important ERAS protocol. ERAS, Enhanced Recovery After Surgery. ERAS. So these are protocol which is suggested. Okay, I think. Thank you. It's very important topic, no? How you are managing a patient, and many things are coming here. Even day-to-day activities, day-to-day work. What are the things you should see in an emergency situation or in an anesthesia setup? You should how you manage this patient. It is there. And every points are very important, as you can see. Okay. So perioperative assessment, history taking, different types of history is important. Then physical examination, thorough physical examination is very important. Then risk assessment means ASA classification by anesthesia they will see. Then cardiac risk, then revised cardiac risk index are there. They will be done usually by the anesthesia people. But you should ask for that, like if you are having duty in the ward, you should send them the call, the anesthetic. They will come and assess the patient whether he is safe for surgery or not. Then pulmonary risk, whether the patient is having breathlessness or any cough or any other ailments, fever or anything, he has to be seen. And what are the investigations we usually routinely we have done? Few investigations like CBC, hemoglobin, TCDC, then profile, how much blood patient is having, whether he is anemic or not. So CBC is very important. Then RFT, then LFT,